Center for Sports Medicine and Exercise Therapy. Thanks to Professor Guidi for inviting me for this lecture. Being from the field of sports medicine, of course, when anybody is mentioning ergometric evaluation, we think about athletes, and we think about pre-participation mandatory screening. In Serbia, we are doing CPAT for our elite athletes. We want to help them, of course, to assess the level of physical fitness and to make the better result, meaning the better training program. But we don't want to forget that our main or ultimate goal is to screen for things that can, cardiovascular abnormalities that can lead to sudden cardiac death. Numbers that we are used to is from 40 to 80, but you will see that today when we are going to talk about heart failure patients, everything is going to be totally different. First of all, heart failure, we can say that it is a pandemic, and the pandemic is because more than 26 million people worldwide are suffering from this disease. Mortality is very high. It is 67% for 5 years after diagnosis. They have many comorbidities, usually more than 3. Concerning hospitalization, it is a #1 cause for people aged 65 and more. And finally, there is a very big economic burden with these patients. I have to emphasize it is not just one single diagnosis, it is in fact the clinical syndrome, and we can, it is the easiest way to define it like just a failure of the heart to deliver oxygen. There are in fact 3 subtypes of the heart failure. One of them is heart failure with reduced ejection fraction, which is in fact less than 40. The other one is with preserved, which is above 50. And in the middle is mildly reduced. Formerly, we call it mid-range ejection fractions, which is in fact in the middle. As we know, there are many causes or etiology of the heart failure, but we have to know them because our treatment is going to depend on the cause. And ergospirometry or ergometry, as you know, can help in this diagnosis, and it is a part of recommendations. There are symptoms and signs, but symptom that is always present is reduced exercise tolerance. So in the stage process of diagnosis, there is always place for the stress test. That is also something that is recommended by European Society of Cardiology in the recommendations for 2021, where they recommend exercise testing for detecting myocardial ischemia. We know this ischemic cascade, but don't forget in this cascade we also have place for cardiopulmonary exercise testing. As for CPAT, as before, it is of course recommending for candidates from transplantation for optimizing prescription of exercise training and to find or identify the cause of unexplained dyspnea or exercise intolerance. I already mentioned comorbidities, and also for these comorbidities, we can use exercise tests to distinguish them. So all in all, cardiac manifestation of a heart failure is exercise intolerance, and that is the reason that New York Heart Association made a classification that is based on symptoms from physical activity, meaning that class 1 is with no limitations and class 4 is with the symptoms that will persist at rest. As for treatment, it is a progressive one, but as we know, there is always a place for exercise, and this is something to assess with ergometry or with ergospirometry. Before, the only use or main use, to say like that, of stress tests was just to be the gatekeeper to more expensive and invasive procedures. But today, things changed. We need this exercise testing, in fact, to make proper decision for our patients. Generally speaking, in cardiology, SPED can be used for diagnosis. It can be used also for early assessing states of disease. We can use it for guiding of response of our clinical therapy, and also, of course, for prognosis. But when we are talking especially about heart failure patients, we have to start with Mancini and his cutoff for candidates for transplantation. Just keep in mind that in that moment, all of them were middle-aged, they were without comorbidities, and of course, they can perform maximal tests. And today, you will see that we are doing it for many different patients. So today, we have new endpoints. For instance, that is a heart failure hospitalization or readmission to hospitalization, left ventricular assist device implementation, or just ICD, to see in symptomatic patients what are the warning signs, or to find in our asymptomatic ones what can be the problem. And don't forget that we need it also for assessing the quality of life. If we want to give our patients for home exercise, something like this, we have to be aware about the things that they can or cannot do. So superior method is measurement of ventilatory gases for, in fact, three things. One is to measure cardiorespiratory fitness. It is not using with equitations, so you can just assess it. This is really measuring. Then to delineate physiological system that is causing some pathological stage. And finally, for prognostic stratification. Just several words about setup of our lab. First of all, you know that devices used to look like this. Today, they are very handy, to say like that. We can use them even outdoors, not just in the labs, and we can also use them for our patients. And if we want to, we can use it also for research. We can choose ergometer, but better is to use the treadmill. First of all, everybody can walk. Maybe somebody is not familiar with a bicycle. And secondly, because we look at value of VO2 peak, and it is like 10% higher for the patients who are tested on the treadmill. Of course, it is very important to assess the effort. So is it a maximal or submaximal? There are different ways, but probably the easiest one is respiratory exchange ratio above at least 1, preferably 1.1. And concerning protocols, it is recommended to use a ramp protocol and increment 1, usually 10 watts per minute on the bicycle, or 1 mat per minute on the treadmill. So usually they're using modified Norton like in the heart failure action study. Don't forget that at the beginning we need at least 3 minutes, not to say 5 minutes of the rest, because our patients have to adjust to the all of devices, and especially mask and mouthpiece, and then try. Of course, we need a recovery period, because we are going to look at dynamics of recovery, heart rate recovery, and the optimal duration on our test should be 8 to 12 minutes. We in fact measuring just 3 things directly with this breath by breath device, which is CO2 output, utilization of oxygen, and ventilation, but together with other devices like ergometer, blood pressure monitoring, ECG, oximeter, and probably arterial line sampling, we can get more than 400 variables. That is also a very big problem, because then clinicians don't know what to do with them, and they don't feel comfortable in such a method mass of data. So first one, people will usually seek for a 9-panel plot of Wassermann, but if we are talking about heart failure patients, we can use, luckily for us, just six charts, which is also recommended. To collect the relevant results and to collect them in consistent and organized manner, and to be able to compare results between the labs, and to really to help our patients, European Association of Cardiovascular Prevention and Rehabilitation, together with American Heart Association, in 2012, and revised was in 2016, propose this chart with the boxes where for various clinical cardiovascular diseases, and just we have to tick what is important for one disease. So in general, a part of this, what we are used to, like things concerning heart rate, blood pressure, resting pulse, oximetry, maximal workload, changes on the ECG, and don't forget the reason of terminating the test. Concerning CP X or PET, call it what you like. There are just 11 parameters, but from these 11 parameters, for heart failure patients, we are in fact using just 4. So these 4, of course, VO2 peak. For athletes, we are calling it VO2 max. For patients, it is VO2 peak. Then ventilation, carbon dioxide output ratio, partial pressure of end-tidal carbon dioxide production, and finally exercise oscillatory ventilation. 3 that I already mentioned are standard part of the data collection that we get, so we don't have to do anything, just to find them and read them. But for this exercise oscillatory ventilation, it looks like this. That is something that we have to look for it, and just to say, is it present or is it not present? Let's start for just some things without VO2 peak. First of all, we know what to expect. For instance, this is something for somebody who is 60 years of age and he is not obese. So if we have physiological case for this person in blue, is what is normal, and this is what he can achieve during the exercise. This one is for a patient who had reduced exercise, reduced, never mind. And this is, yeah, yes, so thank you. And this one is for preserved external fraction. And here you can see just what is going to happen with some features from Fick equation, meaning heart rate, stroke volume, and extraction of oxygen. So just keep in mind that our patients will probably be able to do some things which are in fact less than 20 mils per kilo of oxygen. So just light activities and walking in the space of 5 kilometers per hour. So it is very important to measure VO2 so we can use the FIT principle and to make the proper program for them. But there are some things that are influencing this VO2 peak, and they are not from cardiac origin. That is age, gender, and muscle mass, or to be precise, fat mass. So as for elderly is people who are above 70. We know from physiology that VO2 anyway is going to decline like 0.5 mils per decade. So now we have people with many other clinical conditions. So we have just to be very cautious when we are interpreting these results. Similar is for the women. We know that there is almost 50% difference in VO2 between men and women concerning heart failure. So that is the reason why New York Heart Association gave the different cutoffs for men and women. Concerning overweight, I'm not going to talk about obesity paradox, or is it helping, or when it's helping, but I will tell just that we have to adjust these values of VO2 peak with lean body mass, and in that case, for the people who are obese, meaning with body mass index above 30, then they will then we will use the cutoff of 19 milliliters per minute per kilo of VO2. Of course, we have to be certain, is the test that was performed by our patients maximal one or submaximal one? Usually in everyday practice, it is in fact submaximal one. In that case, we can use some features from the oxygen uptake variables that are independent of volnation effort, like VO2 and ventilatory threshold, or from the ventilatory pattern, also independent of ventilation effort, we can use oxygen uptake efficiency slope. As we know, oxygen uptake efficiency slope is in fact relationship between VO2 and logarithm of ventilation, meaning that higher value reflects improved adaptation. Something that is also suggesting, because it is going to reflect right ventricular pulmonary vascular function during the exercise, is in fact mean response times, and it has to be above 60. I already mentioned that we use our results for prognostic stratification, and here you can see the chart from European Association of Cardiovascular Prevention and Rehabilitation. In green, of course, are people who are at a low risk, meaning more than 90% to even free for 1 to 4 years, and in the red is those who don't have so good prognosis. I already mentioned that we are checking just four things from our cardiopulmonary exercise testing, and the rest is connected with, as you can see, hemodynamics, ECG, and heart rate recovery. But what about people who did not get to the VO2 peak? What about those who just performed the submaximal test? So first of all, we will know that it is a submaximal test by our respiratory change ratio, which is going to be less than 1. In that case, this red is of course people with a high risk, meaning more than 20% of 1 year mortality, and in the green is those who are with almost without risk. So let's go through those with the risk. Those who done just the submaximal test, for instance, they oxygen uptake efficiency slope will, if it is less than 1.4, and if VO2 at ventilatory threshold is less than 9, then together with a slope bigger than 36, and in presence of exercise oscillatory ventilation, of course, our patients are at high risk. Oppositely, if VO2 and ventilatory threshold is above 11, if there is no EOV and the slope is less than 30, there and the low risk. I want just to point out something here, which is in fact that we can look at the other numbers, say like that, for the people who are taking beta blockers. So for them, the cutoff will be 12 instead of 14. And those who are young and who are very slim, or who are with excess weight, meaning obese, for them we will use just we will say that they are in the bad prognosis if their VO2 is less than 50% of the predicted one. There are different also scores that we can use. This one is from Jonathan Myers, and all the things that we already mentioned, including heart rate recovery, less than 6 beats per minute can go in that score. And if the numbers are less than 15, it is a good prognosis, and otherwise it is bad. So different associations are also giving some different predictions, to say like that. This is one group led by Ugo Cora, but you can see that all that we were already mentioning, the type of the patients, percentage of the VO2 max, are they taking or not taking beta blockers, what is the slope, what is the respiratory exchange ratio, is there present or not oscillatory ventilation, also in this chart. Just not to forget to mention this, and I mean, we are trying to help people, of course, and just to assess, did we really help them or not, we will do from time to time or repeat our test, and then we can use this chart and see did we done well, or did our patients done well. So if the numbers will exceed 14, just forget what was before. Now we are on the good track. I already mentioned that we also can,
if you could wrap it up, because we want to keep on time.
Yeah.
Thank you.
Yeah. Also we can use to realize is it a problem with the pulmonary system or with the cardiac disease, and we have, of course, different charts for that. Finally, on the question, is it safe or not for heart failure patient to do the test? Yes, it is safe, as it is a finding from a very big study. So nobody died, 0 deaths per 100 of exercises, and 0.45 non-fatal major cardiovascular events, which was also the result of the new study from China just a year ago published. So instead of conclusion, I will say just let's do it. Let's perform cardiopulmonary exercise test in order to help our patients. Thank you for your time.
Thank you, Professor, very much for this insightful